So this recording is going to cover a running suture. And for the sake of this first video, we'll simply discuss this pattern that you see here. Another video will discuss this pattern. But what you're seeing in the straight lines, both of these are running sutures, is what the patient will see, or what is essentially external. Now, oftentimes, closing a fascial plane that is deep to the tissue, deep to the subcutaneous tissue, you will do this stitch, described by many surgeons as a whip stitch, because you're simply moving your hand very quickly around to get the tissue reapproximated. You can certainly do this on the external aspect of a patient. However, if you can start to familiarize yourself with this technique, you'll actually end up having better spacing between your sutures, plus it simply looks better for the patient. So for the sake of this video, we'll review how to do this type of a running suture and its removal. Now, if you are a left-handed sewer, you would want to start actually on the right side of the incision and sew to the left. You always want to be pulling in line. You don't want to be crossing over the patient. Conversely, if you are a right-handed sewer, you would start on the left side of the incision and essentially pull to the right. Oftentimes, if you are in the operating room and they're doing this surgical procedure and you have a right-handed surgeon, they will be standing to the right of the patient. Therefore, they can start essentially on the left side or on the superior aspect of the incision and pull in line down to the inferior aspect of the incision. So the way that you start this is simply with that typical simple interrupted. Just pull this through. For the sake of today, I'm doing this as a right-handed sewer, even though I'm left-handed. And this is usually going to be an instrument tie, simply because, so you want to pull this shorter so that you have the length of your suture to work with to sew your incision. Pick up the area closest to you. Again, rotating your wrist, use the arc and angle of your needle for a reason. Ensuring here that you don't get your end of your suture caught up in the loop as you pull through. And here we will simply do an instrument tie. Now, oftentimes if you're talking about the fascial plane, we're going to be using like a PDS-2 or a very large proline to actually do this closure. So those are typically O sutures that they're using, still monofilament, okay, but again, an O suture, so much larger. Now, if this was external to the patient, what you'd want to do here is go ahead and cut that tag. Again, similar fashion, go down, rotate your wrist. You want to do that so that every single time you go to throw the needle, that end of that suture is not in your way. Now, to get this line, this is pretty easy. So people say, well, can you just throw the suture across the entire breadth of the incision? And oftentimes, if you're in the operating room, you have someone assisting you, so you can do that. When this incision is wide, however, it's easier to ensure that as you enter and exit one aspect of the tissue, and you readjust your needle, to ensure that you're exiting on the side away from you and entering in the same plane, you will do one side at a time in terms of throwing the needle. Now, you want to ensure that you're not locking the stitch. We'll talk about that. It's yet another way that you can do a running suture for the patient. But this is where you're going to start to see that diagonal line. Basically what you're doing is you're just kind of walking over a little bit. Again, for the sake of brevity here, we're going to push this needle all the way through. And try to not angle it too much here. And what I want you to start to appreciate is the diagonal that you'll start to develop. Again, ensuring that you don't lock this, so go underneath as you grab your needle and pull all the way through. And you can see even here, those two diagonals, although these are relatively evenly spaced, the diagonals are certainly at a different angle. Now, if this is on the fascial plane, no one's going to see this. This wound is simply going to heal. Your body will reabsorb that suture or break it down eventually if it's an absorbable stitch. But third throw, and again, still different. So it's harder to allow these to be more symmetrical, and yet this is what your patient's seeing. Now, regardless of how you do a running stitch, whether you do it in this fashion or in this fashion, or as we'll discuss in a running locked suture, the closure is always going to be the same. So we're going to pull this one through. And rather than pulling this completely taut, this becomes the other half. So you don't just have two ends that you're dealing with, you're going to essentially have three. So if you were to pull this all the way through by accident and then realize in hindsight that you were at the end of your incision, what you need to do is essentially back this out, okay? Because what you don't want to do is end up sewing distal to beyond the wound itself, okay? So you would just use your forceps and essentially back this out. Now here you can do a couple of things. If you really have enough suture material, you can do a one or two-handed tie here, and either would be fine, okay? Be cautious with regard to your needle. And I just prefer a one-handed tie because for me it's much easier. You still cut this suture just as you would everything else. Going down, angle your hand, cut your needle. So how do you take this out? This is now a laceration that a colleague of yours sewed back together, say 7 to 10 days ago. It's on the forearm, it looks well healed, and the tissue all looks well. There's no erythematous changes. So it's time and ready for those sutures to come out. You don't want to simply cut one end and the other, because to pull all of that material through the wound could potentially dehiss the incision itself, the laceration itself. So what you'd like to do is, using your suture scissors, you need to actually cut adjacent to one of the knots. And then what I like to do is go to each individual suture and cut on one side. That leaves one side, the other side, more proud, and that way it's easier to remove. Then of course you need to go ahead and cut at the knot itself, and then what you're doing, you're simply pulling all of this material through. And always kind of pull in line with how you believe the suture was actually placed. And that way you're pulling less of that material that may have been external to the skin through the wound itself. Also, it just simply makes it less uncomfortable for your patient.